Hi, Dr. Stuart Isaacson, the director of the Parkinson's Disease and Movement Disorders Center of Boca Raton in Boca Raton, Florida in the US. And I'd like to talk to you a little bit in the next section about these new options for treatment of off episodes that can be used as needed, on demand. When an off episode occurs, a medication to try to turn you back on again and have improvement in movements. So I think this is an important new way of thinking about different treatments, and it's an important problem. The problem really is focused on the idea that levodopa gives benefit to the motor symptoms, and this benefit persists throughout the disease course over years and decades. The problem is that over time, this long duration response is lost, and the duration of benefit from a single levodopa dose becomes shorter and shorter. 5 hours, 4 hours, 3 hours, sometimes even less. And indeed, each response, the benefit to each levodopa dose may become more variable, sometimes working quicker and sometimes taking longer, sometimes working well, sometimes not so well, sometimes not at all. It's a big problem, as shown here in one survey that listed this fluctuating response, this off episodes, as a number one problem, most troubling symptom in people who answered this survey with Parkinson's disease. And at an FDA patient meeting in 2016, participants really expressed their frustration with these off episodes that could occur unexpectedly and unpredictably, interrupting and disrupting daily activities, and really looking to find better options to try to address these, so that when the benefit of a dose of levodopa is no longer there and motor symptoms reemerge, what to do about it, not having to wait until the next dose is taken, the next dose has a chance to work. Trying to understand these treatment options really is helpful if we understand what causes these off episodes. We think both about central mechanisms in the brain and peripheral mechanisms. The central mechanisms reflect the progressive degeneration of some of the dopamine neurons in the brain, that initially there's a lot of nerve terminals that can uptake extra dopamine and store it for later and release it, sort of buffering the ups and downs and extending the duration of each levodopa dose. But this begins to wane as the disease continues to progress, and buffering capacity can be exceeded, and they get a shorter and shorter duration that begins to mimic how long it lasts in the bloodstream. As well, taking a levodopa and then none, and levodopa then none many times a day may also have consequences and augment some of these off episodes. But it's really the peripheral mechanisms that we're paying more attention to over the past 5 or 10 years. The extreme variability in the absorption of levodopa in the GI tract. Perhaps the problems that we see can be highlighted on these two graphs, and you can see individual patients. Each line on the bottom here shows an individual patient who swallowed a 25-100 carbidopa levodopa. Whether it's in the fasting state, whether it's with a meal, it still is variable. Every dose may work quickly and robustly and rapidly. It may take a while for it to work. Every dose may be different. This really reflects the slowness of the GI tract, what we call GI dysmotility. Just like we have constipation lower in the GI tract, on the upper GI tract, there's GI dysmotility. There's esophageal dysmotility, delayed gastric emptying, and this is related to Parkinson's disease and how it affects the control of this. There's also impaired absorption of levodopa. Levodopa is absorbed in the intestinal tract. It has to go through the esophagus and the stomach to get there, and when it's absorbed, it can be competed with by small amino acids that are in dietary protein, perhaps by bacteria there as well. Compounding this is the short duration, the half-life of levodopa in the bloodstream as it circulates, trying to get across the blood-brain barrier into the brain. And the variability in the blood-brain barrier transport can also be caused by the protein that can be in the diet. So when we think about all the different medications that we have available, we have to think about, how do we decide together, the clinicians and patients and families and caregivers, and together share the decision-making, trying to understand what would be the best type of treatment. We can be guided perhaps by understanding what causes off, but also by the idea that off episodes are different in different people. Sometimes We think about different types of off, the end of dose wearing off, or when someone may take a dose of medication, it takes a long time to work and they have a delayed onset. Sometimes they have a suboptimal on or a dose failure with an extended period where there's loss of benefit of a dose of medication. Off episodes can be frequent, can occur many times a day or just once or twice a day. They can be very severe when they occur, or they can be mild with mild slowness. Others may have severe immobility. In one study we saw recently that patients on average had 4 off episodes a day, each one lasting about an hour. So it can become very problematic. We can think about the timing of off episodes occurring overnight with overnight offs, or first thing in the morning with early morning off or morning akinesia. The off can occur between this dose or that dose. It'd be different every day. It can occur around mealtime due to an effective protein called postprandial off. We can get sudden offs or unpredictable or unexpected offs. And really, we have to focus on how off episodes impact daily life and daily activities, how we might see any problems when we're going to do exercise, or trying to go and do physical therapy, or trying to go out to dinner or to see family members. If off episodes occur, we might have to wonder, oh, how is it impacting daily life? We may think about different medications and access, which is so important that people can get access to these medicines through formularies and copays and such. How it's dosed, the route. If someone is having a delayed onset, we might want a non-oral route. Think about the development and the research studies that show the efficacy and tolerability and safety. And think about how the drugs are cleared and how they work. And our patients also have to think about their comorbidities and concomitant medications, prior sensitivities to medication changes, non-motor symptoms that may be there. They may be limiting peak dose dyskinesia or psychosis or orthostatic hypotension that can impact our treatment decisions. This cartoon here sort of highlights those. We want everyone to be on the top green consistently without troublesome dyskinesia and without having this transition to off at the end of a dose. We don't want to have a delayed and a prolonged off period. So we want to think about these times when a dose of levodopa gives benefit, but then the benefit is no longer there and off symptoms occur, and we have to wait for the next dose to be taken, and sometimes have to wait after it's taken until it begins to work a variable amount of time. Here we can understand a little better, perhaps, this idea of how important it is for levodopa delivery to the intestinal tract. Perhaps the great irony of having our cornerstone gold standard therapy of carbidopa levodopa is that it's oral, that it has to be swallowed, has to go through an esophagus that has this motility into the stomach, which can be slow to empty due to gastroparesis. No absorption occurs until it leaves the stomach and enters the small intestine. And even there, it can be impacted by protein or bacteria. Here we see in this graph here in blue in patients who have a good response to a dose of levodopa, and those who have early morning off with the delayed onset and how that absorption is reduced, probably due to gastroparesis and delayed emptying of levodopa into the intestine in red. And this is what we're talking about. What do we do with people who have this trouble with absorbing levodopa, especially first thing in the morning? In the picture, we can see a picture of a dose of carbidopa levodopa and how it's still there 90 minutes later. This is the patient who has the pill still in the stomach and it's not getting into the plasma. So they're in red here. And here you see that pill still sitting there waiting to have a chance to work. It makes us wonder, how do we treat these off episodes then if the pill has such difficulty getting through the GI system and in and out of the stomach and into the intestine to be absorbed? Oral carbidopa levodopa sometimes works very rapidly and robustly, but sometimes it doesn't work in 15 or 20 minutes. Sometimes it takes 30 or 40 or 50 or 60 minutes to work. And even when we try to use the orally disintegrating tablet, it's still a solid in the stomach and will stay there too long. It melts in the mouth, but is solid in the stomach. Liquid carbidopa levodopa can empty a little bit faster because it gets out of the stomach and drips out with the liquid, but that can be difficult to do routinely. It's why we've sought so hard to study these non-oral formulations to try to be used to treat off episodes on demand or as needed. And I'd like to tell you a little bit about these non-oral therapies and to think about them a bit more. There are 3 that are currently available in the States, and then one that's available in Europe and elsewhere in the world, and hopefully they'll become greater available globally, all these 3. Let's talk first about a formulation of levodopa that doesn't have to be swallowed, but is inhaled. It's inhaled through the mouth into the lungs, and it goes right through the alveoli, into the lungs, straight into the bloodstream, bypassing the whole GI tract. So it gets into the plasma really, really quickly, and we can see an onset of action in about 10 minutes and a full turning back on in about 20 or 30 minutes. So this is another way to take levodopa. It uses this little inhaler that's in blue and white here, and the 2 capsules go in. That's 1 dose, 1 capsule at a time. It's the equivalent of about half of a carbidopa levodopa 25-100. And we can see that improvement. So when you first start to wear off, you have symptoms, you can breathe this in and turn back on and use it whenever you need it, up to 5 times a day. The biggest side effect might be cough, but if you breathe in gently, you might be able to have less cough. Apomorphine is a molecule that works as robustly as levodopa, maybe more in some people's opinion. It's been available for 15 years in the States and about 30 years in Europe. And it has a subcutaneous injection that can work very rapidly within a few minutes and seeing a full effect in about 10 minutes. And it can really be something that can be rapidly and reliably turn somebody on when they're in the off state very robustly. And more recently, we've had the same apomorphine, but instead of an injection, a sublingual strip that goes beneath the tongue and then gets absorbed through the mucosa directly into the bloodstream. And this can have an onset of action in about 15 minutes with a full on in about 30 minutes. So I think these are 3 ways of thinking about using an on-demand therapy as needed, once a day in the morning, multiple times a day, up to 5 times a day, to try to have a turning on when the GI dysmotility results in a delayed onset. It leads us to thinking about a paradigm of treating Parkinson's disease, where we use a lot of different ways. We can increase levodopa, we can take them closer together, we can add adjunctive dopamine agonists and COMT and MAO inhibitors and even non-dopaminergic agents on the adenosine and glutamatergic pathways. And now we have an on-demand therapy group where we can also, rather than having to choose between getting a longer duration of benefit or treating as an as needed or on demand, we can do both. We can, as we try to adjust levodopa or raise the dose or adjunctive medicine, also give an on-demand as needed therapy. So when a patient is in an off state, they can be empowered to have something with them that they can use to turn back on more rapidly and more reliably than perhaps having to swallow a dose of levodopa or not really knowing how long it will take to get through the GI system and to get out into the gut and be absorbed. Of course, we have other intermediate subcutaneous therapies that are available in some places in Europe, not in the States, and being studied in others, advanced surgical therapies, many, many different options, new drugs coming along and being studied. So I think there's a lot of hope to being able to continue to treat Parkinson's disease throughout the multi-decade course. So thank you for your attention, and I hope to answer any questions you might have.